Okay, so yes, so my name's Paul Doolan. Thank you for attending today. I'm going to talk to you about our clinical experience in our center using the SunCheck platform. Okay, personally, I don't have any disclosures to make, but I should mention that my presence here is sponsored by Raymed, but they didn't influence anything I say or anything in these slides. So I'm from the German Oncology Center. We are located in Limassol in Cyprus. We have this fantastic view over the Bay of Limassol. I'll just spend a few moments explaining about our center so some of you are not aware. We're an active research center. We have a number of collaborators. We're involved in a number of ongoing projects. Here are some of our highlights. So our daycare patients have this fantastic view while they're having their chemotherapy over the whole Bay of Limassol, which is really very nice. The nuclear medicine patients that have therapy benefit from this isolated garden, which they can experience during their isolation, so they can benefit from the 330 days of sunshine that Cyprus has every year. And we have the island's only PET scanner. We have a state-of-the-art radiology department housed by a Siemens 3T Vita, which has deep learning reconstructions. And I was going to say it's the latest model of CT scanners, but if you're just here for the previous talk, you'll see that the photon counting has kind of overtook it. But the Siemens Somaton Force is still very, very good scanner. There's only, I think, 13 of them worldwide. Allows us to conduct all manner of cardiac examinations. In radiation oncology, we have 2 Linacs, a Versa and a Synergy. We have 2 planning systems, Monaco, but we're slowly migrating to RayStation, and an extremely busy brachytherapy unit. Here are some of the brachytherapy procedures that we produce under the guidance of Professor Zamboglu and his team. All manner of things happening with CT guidance and also ultrasound-guided prostates. Okay, so let's move on to what I'm going to talk about today. I'll talk about the SunCheck machine, SunCheck patient, dose check and fraction 0. And then the rest of the talk will be related to in-vivo monitoring, which in SunCheck is called fraction n. So let's start a little bit about SunCheck machine. So this is a suite that's offered by Sun Nuclear, and it allows you to sort of streamline and automate your machine QA processes. You have integration available with some devices which you maybe already have, like the ArcCheck IC Profiler DQA3, and then there's also some tasks which used to be called SNC Machine, which I'll spend a little bit more time talking about how they automated these tasks. They allow you to perform mechanical and imaging checks as per TG142, so those checks you see there. The advantages that we see are that it's a single database, allows you to trend so you can spot if something is out of tolerance. If it's out of tolerance, you know that it has been trending out of tolerance. There's a system for approvals, email alerts, and report generation if you need that as well. So let's see if this will play. And you're going to hear my voice, so I'm going to go quiet and you'll hear my voice speaking.
Okay, so here we have the home page for the Sun Nuclear platform. It's accessed with a web browser, so we just simply type in the IP address within your institution, log in, and you'll have access to this database from any PC in the center. So we have a patient work list and a machine work list. We're looking at machine in this case. You can also access it from the top. Here is the machine, and here we have our different machines that we have. We have our microselectron, our HDR brachytherapy unit, and our 2 Linacs. Let's have a look at Versa HD. This is the most recent instance of SNC machine QA that we have. And down on the left hand side here we have all the different tests that we do. So a collimator star shot, picket fence, asymmetric fields, symmetric fields, Hancock tests, Winston-Lutz, MV, KV, and CBCT for the different protocols that we regularly use. So I'm going to find an old test that I know is a good one to show. May 2021. And in this instance, some picket fence tests were completed after an agility calibration. Here we have that the 180 passed, the 270 didn't pass, the 0 passed, and the 90 didn't pass. Let's have a look at the 180. Okay, so here you have the individual task execution page for picket fence at 180 degrees. I can look at the image myself, which is what you would have ordinarily have done in the olden days by looking at a film and run your eye up and down and try and look for any errors. We can zoom in on this like I just did. I can change the window level should I want to. But this is just as a visual check, it looks okay. Quantitatively, I'm looking for leaf gap errors of 0.1 millimeters, and in this case there are 11 leaf gap errors more than 0.1 millimeters. I can see where these are within the different strips. So I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and the blue ones are ones that are a bit too small, and the red ones, or the orange ones, are ones that are a bit too big. But how big are they? Well, across all of those 11, the maximum leaf gap error was still only 0.2 millimeters. How does this compare with previous results? Let's have a look at a quick trend. And I can see that actually the leaf gap error has always been around this value, 0.2 or less. So we can be pretty happy with these results.
Okay, so let's move away now from SunCheck machine and move to SunCheck patient. So I'm going to talk about dose check and fraction 0 to start with. So you finished your plan in the planning system. You then send it to the Sun Nuclear server, and there's actually one more option available here, but we have these three options. Dose check, which is the independent dose calculation. Pre-treatment QA, which is assessed for us with per fraction 0, and then the online treatment monitoring, which is per fraction in. So let's start with dose check. And I have another video, not quite as long this time.
Okay, so now we're going to have a look at some patient cases. After you send the plan from the treatment planning system, it is automatically detected by the server to be a clinical plan. You will send your images, your structure set, and your dose, as well as your plan, and it will be automatically organized here. So I'm going to show you a non-clinical case, but test RT-safe as the patient with its ID, and we can find a plan here. We're going to look at the interrupt plan. So this has what's called a dose check event. So this is the secondary independent dose calculation algorithm check. Then it's had some pre-treatment QA. So this is called fraction 0, so it's before fraction 1. And in this case, there's no in vivo monitoring. We'll look at other cases for that. So let's look at the dose check. Okay, so what we've got up here is we see some points analysis. You can also look at targets and OARs if you have them, how well they match what was planned, and the overall gamma, so a 3D gamma analysis. So this section here, basically here, is the points, and we can look at an individual point on the plan and see how well that matches. So here we have a relative dose difference of 1.4%, which would be acceptable. We can then scroll down and see, okay, in this case we had some targets, which was a structure called tumor. It had 100% gamma match between the plan and the secondary dose calculation algorithm, and all the organs at risk also passed. You can also see a 3D gamma. So here we've got an actual visualization of that. So here is the calculated. This was what was calculated by per fraction. This is the dose distribution that was planned. and this is the gamma difference map. In this case, no difference at all.
Okay, so we've seen dose check. We've passed our dose check, our independent dose calculation. Let's move on to pre-treatment QA. So perfraction fraction 0 for us is used for all VMAT cases. We like it because it's phantomless, so it's completely done in air, it's EPID-based, and it's a fully automated analysis. There's not much for us to do. And then it's integrated with perfraction. So the results are automatically pulled into the server for each patient. And then this is the last video with my voice.
After you have performed your dose check, you can then go and have a look at the fraction 0. So this is your in-air pre-treatment QA delivery of the plan to the EPID panel. So based on the plan that you have sent, it will calculate an expected image map in the panel. You can deliver the actual dose on the machine to the panel. The two will be compared and you'll have a gamma map which will be analyzed and give you a specific passing rate based on the relevant settings that you have applied. So we follow AAPM TG218, so it's a 3%, 2 millimeters, 10% threshold with 95% passing rate on a global normalization. And in this case, we have a 99.6% pass rate. So we're looking for anything above 95. And you can have a look at different profiles. It's a nice software. I can look at that case that just failed up here. And I can see that there's just some small error here. But overall, I think we'd be happy with this plan.
Okay. So now let's move on to the in vivo monitoring using, in this case, I'm going to talk about using the EPID. So this is the third section, online treatment monitoring. It's called perfraction fraction N in this software. So why do we want to do online treatment monitoring? Well, radiotherapy is complex. And this elective video that you can find on YouTube starts to go through all the different variables that we have to think about in radiotherapy. So we have field size, we have the positions of X1, X2, Y1, Y2 with time. We have the dose and the rate at which it's delivered. That can vary with time. We also have, let's wait for the video to catch up. We have the gantry position and the gantry speed. These can vary with time. We have the patient position. So this can be varied in the 6 usual directions, as well as rotationally. Then as well we have the collimator angle. And then of course we have the MLCs as well. And for us we have 160 MLCs. The position of all of those can vary with time. So there's a lot of things going on. So we like to split these different variables and into different sources of error that can happen in radiotherapy. The majority of those are changes in the radiation beam. We have also changes in the patient position, and then not included in the video, potential changes in the patient anatomy, either from planning CT to fraction 1 or from fraction 1 until fraction N. So why do we want to do online monitoring? Well, I'm a firm believer that we should always be looking to try and improve our service. We owe this to our patients. But as well, in radiotherapy, we are dealing with more complex deliveries, increasing dose per fraction, shorter numbers of fractions. And as well, it's not the case here or in Cyprus, but there is legislation coming in other areas of the European Union. In France, they have to do online treatment monitoring, which means it will come here eventually. There is also the issue of reimbursement, because this is an extra task for physicists, but I think that will also come as well. So we are looking at this for the future. Okay, so we're going to do online treatment monitoring. Why should we use the EPID? Okay, what is the EPID for those that don't know? So the EPID is the large field detector that comes free with every LINAC. In radiotherapy, we're using high energy X-rays. So they exit the patient out the other side, and we can capture this dose. Why not capture this dose? We can have an expected dose map and compare this with our measured dose map. We can integrate over all of our angles for a VMAT treatment. And then we could make a comparison between them. You can compare them any way you like with gamma analysis, dose difference, all sorts of other measures. So at this point, I'm going to poll the audience. We have quite a full audience. Just show of hands for anybody who routinely uses EPID for in vivo dosimetry. Maybe two, three people out of quite a big audience. So if we compare this with what's going on elsewhere, in the UK, we did a survey in 2020, and just around a third of UK hospitals use the EPID for in vivo dosimetry. 2 years later, there was a SunCheck users survey, which was worldwide, and that number is up to 60%. So that could be because we're 2 years further along. It could be because they're using the SunCheck software, maybe a combination of both. In that UK survey, 87% of UK hospitals believed that the EPID should be used to monitor every patient. So this is almost unanimous. So why the EPID? They gave reasons in an empty text box. And here they are kind of ranked in order of frequency of what people said. So most people said because the measurements are influenced by the presence of the patient and that the whole treatment field is being assessed. All right, so we've decided we're going to do online treatment monitoring. We're going to use the EPID. How sensitive is it to detect these three sources of errors that we talked about? So we did a study that was published last year in the Biomedical Physics and Engineering Express journal. So I won't have enough time to talk about it here, but you can read that. I can give you the paper if you need. We also did a webinar on Physics World last year, which went into it in much more detail. But I'll go through a little bit. For changes in the radiation beam, we effectively delivered a square field size and delivered it again with tiny errors, different MUs, different collimator angle, different field size, and we found that it's, suffice to say, very, very sensitive to changes in the radiation beam. For testing patient positioning, we used the RT-safe pseudo-phantom. We created 3D CRT and VMAT plans, so static beams and arc beams, delivered the plan with the phantom in the correct position and with small lateral movements, 1, 2, 3, all the way up to 40 millimeters. And the results are a little bit surprising to us. For static beams, provided you change the heterogeneity that the static beam passes through, it's very sensitive to, say, 3 millimeters. But arc beams, when we analyze them with gamma analysis, so 3%, 2 millimeters, these were analyzed with, you could shift the phantom 3 centimeters and you would still get more than 95% passing. And actually, though, when we consulted the literature after this, we found that this was very consistent with literature. And it's the effect of using gamma analysis. The 3% and the 2 millimeters combination masks the they talk about the gradient-rich fluence, and the heterogeneities of these fields gets masked. If you take away the DTA and go down to just 3%, you can then reduce that 40 millimeters down to 10 millimeters. So it can become more accurate, but you need to know that the EPID is maybe not the best for detecting changes in the patient positioning. For patient anatomy, we used a cylindrical phantom, which was kindly loaned to us from the University of Athens, and placed 3 pieces of bolus on top and sequentially imaged it after removing pieces of bolus. In this case, the arc beams, it was more sensitive to the arc beams than the static beams. But like I said, for more full details, consult the paper or the webinar. All right, so now I think the more interesting part of the talk, coming into the end of my talk, to talk about how you actually implement this in practice. Let's start with the frequency. We only had 3 people who said that they use the EPID for online treatment monitoring, but you have to think about how frequently you're going to do it. So you could go for anywhere from first fraction, first 3 fractions, weekly, the fractions where you don't do CBCT, the fractions where you do CBCT, or all the fractions, or some other. If we look at the surveys that have gone by, and also compare with our centre, in our centre we use it for every fraction, every patient. So we're in the all fractions section. The UK users in 2020, around 40% of them, the majority, were doing it on the first fraction only and not doing it again. Only 6% of them were doing it every fraction. 2 years later, on the SunCheck survey this year, we're at 22% doing it every fraction. So it's 3 to 4 times more. Personally, I feel it's because of the SunCheck platform automates it. It makes it much easier for you to do this. But when you're considering your frequency, you need to think about quite a lot of different things. So I'll ask a lot of questions. Who's going to perform the task? Is it a physicist? Is it radiographers? Do you have the staff to do that? If it's a radiographer, do they know what to do when something fails? What's the chain of command? What patients are you going to include? Are you going to include all your sites, or are you only going to include those that you think are going to undergo anatomical variations? Modalities-wise, you go from 3D CRT to IMRT, VMAT stereo, you become more conformal in your dose. So maybe you should do it more regularly. You should have more stereotactic cases should be monitored in vivo. But the stereotactic cases, the dose fractionation is shorter, so you're not going to see anatomical variations. And maybe there's some exclusion criteria, like fields that are too large, that will irradiate the electronics, and non-coplanar beams are obviously out of the question. When? How quickly do you need an answer? Patient numbers, staff resources, how fast is your software? For example, the dosimetry check software takes around 45 minutes to give you an answer for one patient, one fraction. So you really have to think about what you're doing. And why? So what area are you trying to catch? And let's look at the 3 sources of error we talked about before. If it's machine error, and it's beam delivery error, feasibly that could happen any time. So you should probably do all your fractions. If it's something that you made a mistake in the TPS, then you're probably going to pick that up on your first fraction. Similarly, network transfer errors, you're probably also going to pick that up on your first fraction. If we go to patient misalignment, setup errors, incorrect immobilization, you should be checking that on your first fraction. You could maybe say the first 3 fractions if the patient is starting to relax into their position. For us, we have matched Linacs, so potentially different radiographers or radiation therapists could be setting up the patient from 1 week to the next, so you maybe might want to do it more frequently. Anatomical variations, it depends what you're looking for, whether you should go for the first few fractions. So usually our patients have a strict diet that they must follow. They may get that right after the first few fractions, 3 fractions. So then you might want to just monitor that weekly. Weight loss, tumor shrinkage, this is probably something you're going to monitor periodically. I'll just show you a couple of examples in our clinic. This is a prostate example. So at the top we have the predicted fraction N map based on the plan and the CT and the structure set of the patient. And underneath you have fractions 1, 2, 3, and fraction 9. And underneath those, you have the gamma comparison between those fractions and the predicted. So it started off on fraction 1 at 99%, 94, 93, and then by the time we got to fraction 9, it was less than 90%. And for us, this would be a discussion for a replan if that discussion hadn't already started. This is a stereo case, thoracic spine case, and currently FFF doesn't allow you to have a predicted dose. So fraction 1 actually acts as the baseline here. And then fraction 2, you can see, is a very, very good match with fraction 1. Okay, and then the last thing to talk about is thresholds. So setting thresholds is really, really difficult. And in the UK survey, it was considered to be one of the main barriers for people to adopt EPID in vivo dosimetry. And I'm going to talk about different approaches you can go to setting up your tolerances. In radiotherapy, we've been used to using gamma analysis for machine QA for years, and we're used to using 3% 3 millimeters. So that could be a place to start. Patient-specific QA is 3%, 2 millimeters now. But we're talking about patients, we're not talking about phantoms. So is this really appropriate? You can scour, ask other people what they do. So in the UK, the SunCheck survey this year, quite interestingly, there was a 50-50 split between centres, established, very experienced centres, setting gamma criteria with 10, 7, 5% in their gamma criteria. But they're looking for gross errors, big errors. They don't want to see many failures. But then there are other centres looking at setting 3% and 2%. So it depends really what you're trying to check. You can look back on literature. I did this for the past 10 years, and overall you're looking still at 3%, 3 millimeters. This is what people were using. Empirically, there's this landmark paper from a couple of years ago from a group in Belgium, which have really, I think, set the standard of how to do EPID in vivo dosimetry. And they started with 3%, 3 mils, and varied as necessary site by site. So for breasts, they increased it to 7% because this would avoid clinically irrelevant patient thickness changes like breast swelling. But then they also had to lower their passing tolerance to 90% because they were seeing lots of failures due to the flash that is added to those fields. Head and necks and brains, they kept it 3%, 3 mils. They wanted to be very sensitive. Stereotactic cases, they used local normalization to make it, to not mask any errors. And then because of the very large dose gradients that are created, they used 10% dose difference, which I was a little bit skeptical about until I heard Professor Paddock's talk earlier, where he said that they're using 5%, 1 millimeters for accreditation for SRS, and that's with phantoms. So this is probably a good number. You could also look at replans. You can look at statistical process control. But in general, there is a lack of guidance out there. I'm part of the Working Party group in the UK, the IPEM Working Party group, who did the survey, and we're following that up with some guidance, hopefully, in the next, either this year or very early next year. And also there should be a formalization of this SunCheck survey as well. With that, I'd just like to draw my presentation to a close. I will like to acknowledge my colleagues who, this is a team effort. This is a really big job. I also would like to thank Sun Nuclear, the different institutions that loaned us their phantoms, and of course Raymed for sponsoring my presence here, my references, and I'll invite any questions. Thank you.
Thank you, Paul, for this very interesting presentation on the use of EPID for both machine QA and patient QA, pre-treatment and in vivo. It's really a topic that is evolving, and it is used more and more in our hospitals. Are there any questions from the audience? Maybe we have time for one. So EPID has been around for some time. So why is it now that we're seeing the drive for its use for online treatment monitoring?
Yeah, you're absolutely right. EPID has been around for a long time. It's been used, and it comes with the Linux for free. But I think now the software is finally catching up. To do that automation, it was too big a task to monitor every fraction, every patient, to manually change those images into absolute dose, to compare them with prediction. It just wasn't possible, but now I think the software's there that allows us to do this.
Thank you very much. If we have no more questions, would you like to add something?
Thank you very much for the talk, Paul. That was a very good talk. As being fraction users as well, it is a very, very useful tool in the clinic to have, and it can definitely help with improving patient treatment. Thank you.
Thank you.